So good morning, everybody, and welcome to our QHSC training. Today is the 28th, and we are doing postpartum hemorrhage screening and management. So discussion today, we are trying to walk the patient through from admission to delivery to postpartum hemorrhage event, and then to the transferring from lower level, make level 1, level 2 to tertiary center for due to postpartum hemorrhage. So it does matter when we see these patients from the beginning. So we need to be able to learn and identify early. And then so we have our facilitators and today to help us discuss this process of knowing the patients, identify as soon as you see them, and then what exactly do we need to know? And then after that, we have the discussion, the 2 case studies. So the first case study is addressing initially on the labor and delivery, how they identify the patient and then manage their postpartum hemorrhage. And then the second case study is now if that patient was not managed and then they have to be transferred to Muhimbili specific for this discussion purposes. So what exactly do we need to do to prepare for this patient? So to guide the discussion today, we have a number of objectives that we need to try to attempt to understand and address. So we are going to define the postpartum hemorrhage. From each hospital, we need to know the criteria that they use to define what is postpartum hemorrhage. So we can share best practice and learn from each other. Then we're going to identify the process of screening. How would I know if this patient has postpartum hemorrhage or is going to be at risk for postpartum hemorrhage? Then we're going to discuss the risk factors. So when we know this risk factor, then we'll be able to understand if the patient shows up like that, then we need to get ready for them. And then we're going to discuss the medication. So we need to know which hospital we use which medication. So if it happens, every hospital uses the same medication, whether the patient is in Tanzania, so we're going to have a doctor from Sweden, or if it's in USA, then if the patient is going to get the same care, the same medication. And there's just a discussion phase to know, okay, if we're using a massive transfusion, how do you do it? And if it's something that we can share practice purposes, yes. I know some of the things that have been done during massive transfusion may not be available in Tanzania, but we can discuss and see what are the options we have. Another objective, we need to identify the current practice for transferring. So how would I prepare this patient from one area to go to the next? And what is the expectation for the receiving hospitals? What do they want that patient to have before that patient arrives at the hospital? And then the last one is management. How can we prevent this? So after learning all this, objective 1 up to 6, so how do we prevent it? And we do have a little video for the non-pneumatic Anti Shock Garment to help us, especially for the lower level hospitals like level 1, level 2, like a Buguruni and Mwananyamala. If need be, the patient needs to be transferred to higher level, which in this case is Muhimbili. Can we use this garment to try and help stabilize the patient until the patient gets there? So when the patient arrives to Muhimbili, they are in a better chance of being resuscitated accordingly to their situation and have a better outcome. So, okay, so just that was a little background of all the objectives today. And we're gonna have Dr. Gwen Randall, who is a seasoned anesthesia provider with more than 25 years experience. She's an educator and researcher, and her passion is the participate in the mission of caring for the least of these. I'm gonna I'll just say hi, and then we're gonna go to the next person, and then Dr. Gwen is gonna start with the discussion afterwards. Dr. Gwen, go ahead.
Good morning, everyone.
Good morning.
Finally have an opportunity to meet everyone and have a discussion. I'm looking forward to the information that's going to be shared here today. And hopefully we can change some outcomes in Tanzania. Thank you.
Thanks, Dr. Gwen. The next person was supposed to be Dr. Mugaru, and we're going to let her come in and introduce herself when she gets in here. But she's one of the registrar at the Mwananyamala OBGYN department, and she is involved with the previous discussion about this the postpartum hemorrhage and diabetic screening. So we are looking forward to hear her feedback and preparation for this discussion today. We have Mr. Kamana Hassan, is a registered midwife from Muhimbili National Hospitals, and he also, I think, specialized or focus area is the preeclampsia and eclamptic unit. So he's going to share his feedback with us, especially the second case study, because that was, he provided that. So thank you very much, Mr. Hassan, for that. I'm going to let you just say hi, and then I will let.
Yes, hi.
Hi.
Yeah, I'm very humbled to join today also as a last week meeting. Yes, I'm here to share with you the case presentation that we will be discussing all together today. Thank you.
Yeah, thank you very much. We appreciate, and thank you for providing that case study, which is going to give us an eye-opening of how to address those things. And all the discussion that we're going to have today is the learning. We want to try to share this practice. So we appreciate giving us the cases so we can run through and see if that patient was in, what is going to happen if that patient is on different hospitals in Tanzania, what the patient is going to do.
Thank you.
Makura is one of our regular participatory, facilitator here in QHSC, and thank you very much for devoting all that time to come and attending previous training for the fetal monitoring, for diabetic screening, and now for postpartum hemorrhage. We know they're all related, so thank you very much, and I'm going to let her say hi to, and later we hear from her. Dr. Emma.
Good morning. Yes, can you hear me?
Yes, we can.
Okay, great. Good morning, everybody. It's wonderful to be here again. And I am an obstetrician and gynecologist practicing in private practice in Greensboro, North Carolina. I've been practicing for just over 15 years, and I am happy to come back again to learn and to share. So thank you for having me again.
Yes, just make sure you keep a chair, and you're going to be here for a long time. So thank you. I appreciate your presence every time. I know I keep bugging you. Come and share.
No problem. It's wonderful to be here.
We want to learn from you. So thank you very much. I know Dr. Moses Mulungu, I didn't add your name in there, but I know I'm going to solicit your feedback throughout the day today. You want to say hi to everybody? Dr. Mulungu?
I am Dr. Mulungu. I'm an anesthesiologist working at Muhimbili National Hospital. I'm happy to be with you and share the knowledge, and maybe also try to gain knowledge from you guys from America. You know, it's a developed country. America is a developed country. We expect to learn from you more than you to learn from us. Thank you.
Thank you, Dr. Mulungu, you're being humble. But no, we do need to learn from you guys, because remember, yes, in America, we are privileged and we have all these resources, and still the variable tool that any provider can have is their brain, learning, and critical thinking. It doesn't matter how much resources you have. If you don't have critical thinking, you're not going to work. And you guys are in Tanzania are privileged enough that even if you don't have those resources, you have to use your brain to be critical thinker so you can address those situations without all these assisting stuff. So that's what we want to learn from you, so we can share both of our best practice. And then when we have the resources, yes, we can use it. But if we don't, we should be able to use what you guys are using and enhance it or improve, so we can make sure the patient is safe. So thank you for being here. I know Dr. Msabichaka probably she's hiding. Hi, Dr. Msabichaka, Dr. Benera, thank you for being here. And Mwananyamala also now is here. Thank you very much. And we're going to start now. I'm going to let Dr. Gwen Randall start.
All right, so my question was, when is it time to let her go? And so I'll be just talking about some general, hold on.
And I think you were
Okay, be talking postpartum hemorrhage. It basically, not only in Tanzania, but also in the US, it's a major threat. And what is being said is pretty much is preventable, because if we have good identification, good clinicians, good staff, then we can alleviate some of these problems. So we talk about skilled attendants, so which means that, you know, people who basically can support the progression of the labor, individuals who are knowledgeable about complications that could potentially happen, and then the proper and timely interventions if complications do develop. So the definition there was an old versus a new. Originally, it was said that postpartum hemorrhage is identified as 500 cc's if you have a vaginal delivery within 24 hours, or 1,000 for C-sections. However, it's been redefined now to say, listen, if you have blood loss of 1 liter or more, it doesn't matter whether the patient has a vaginal delivery or the patient has a C-section. Basically, if the patient is symptomatic or hypovolemic, it doesn't really matter where the source originally. So although we can identify the patient, we can go through and we can talk about the risk factors, you know, parity, we talk about obesity, we can talk about, you know, the different things, age and those things. But the most important factor for us to discuss is vigilance, you know, making sure that we have a team of people who are on top of what's going on with the patient and able to identify quickly what's going on and call the team in for assistance. So the 4 T's are, which would get us into trouble with these kind of patients, would be tone, which is urine atony, trauma, if there's been any kind of lacerations or uterine rupture, also tissue, if there's been retained placenta or clots, and then if the patient has any kind of clotting deficiencies. In terms of anesthesia, anesthesia is one of the major stakeholders in the labor and delivery suite. Anesthesia should be readily available. And so, you know, when we're talking about the patient comes in, do we have a team of people who are coming in already bleeding? Do we have that team assembled? What is the time factor between the time the patient arrives and the time the team is assembled? And what kind of protocols do you have in order to provide the level of care that you can provide for those patients prior to that patient being transferred? And then also looking at the time that from the time the patient is admitted to the time the patient is transferred. When you have to factor in those things, what we've heard about, you know, you have to get the patient there, you have ambulance, you have traffic and all those kinds of things. So what kind of things can we do to try to minimize or maximize that patient's care? And so one of the things that we're going to be talking about is the non-pneumatic shock devices. And hopefully I've been in contact with UNICEF and we're trying to work on, you know, seeing if we can get some of those devices there in Tanzania when we come. Anesthesia should actually be involved in providing not only in the OR, but also at bedside. So in the US, a lot of times we already have anesthesia providers who are assigned to OB. So that patient is evaluated when that patient comes in. Anesthesia is readily available should anything go on. And the nurses are in really good communication with anesthesia as well as the OB. So the team is pretty well set in terms of how we handle these individuals, but still patients do bleed. So we should be doing a pre-anesthesia assessment on everybody and also developing a plan. So for units here in the US, if anesthesia is already assigned, a lot of times when I'm doing OB, if I'm there, I'll assess every patient as if that patient is going to bleed, take a history on the patient. If the patient goes through a normal vaginal delivery, well, that's a great thing. If there's any kind of complications that develop, we don't have to run around like chickens with our heads cut off trying to figure out what's going on with the patient because we already have a certain amount of history. So we should always be prepared in the labor and delivery unit. We should always be set up. We should always be ready to go. And so that's one of the criteria that we use here. Whoever is on OB call, that room is set, ready to go, and there's no, fumbling around. We should also be evaluating what the anesthesia options are and have a good history of the patient, and so what we're going to do for that patient post-op. You really, when we talk about making changes in outcomes, it's really about power. We have now, as a team here, as we prepare to come to Tanzania, we're trying to maximize the knowledge that we have, the knowledge that we can share. We're also really grateful that we can have this shared understanding and responsibility between the US and also Tanzania, and try to change some outcomes. That we have an opportunity to communicate with one another, we have an opportunity to collaborate, and then we also have good leadership. So those are the things that are really going to make a difference. And I think that as we are here, we're like team, and we're developing team dynamics. So when we come on board, boots on the ground, then basically we've already kind of developed our plan and everything should go smoothly. Harriet, do you want me to talk about this now or?
Not yet.
Okay. So in terms of protocols, this is a protocol that I actually was just really published in the New England Journal of Medicine. And it talked about from the time the patient comes in, you should be screening those patients for postpartum hemorrhage. What are those risk factors? And once again, I say when the patients arrive on the OB suite, then that information is communicated. And a lot of times that information we already have on board. So we're preparing for whatever emergency could potentially. We're always going to make sure that we evaluate the patient's hemoglobin level prior to a delivery. And then any kind of consultation that needs to happen, then that is taken, that is done. So on admission, again, we see here, we're always going to be assessing these patients for postpartum hemorrhage risk factors. And then we categorize these patients in terms of strata, whether they're high, low, or medium for that. So we should always have an IV on board. And so we put in 2 large IVs for patients who are at increased risk. So maybe you may not run the IVs, but you may just have the map there. Anesthesia basically should always be notified in the event that there could be a potential problem. But like I said, for the most part, anesthesia is normally readily available. And then it goes through the development of postpartum hemorrhage, as you can see there. If there's an estimated blood loss of 1,000 to 1,500, then there's a protocol, as you can see there. If it's greater, 1,500 to 3,000, there's a protocol. And then if it's greater than 3,000, then basically you have the protocol using all the different drugs, which we can discuss as we go. This non-pneumatic Anti Shock Garment, there was a really good article, which I basically gave you access, or you can look it up online, where UNICEF really talks about the importance of using this garment. If you do not have the capabilities to care for these patients and the patients are actively bleeding, it kind of buys you some time. It doesn't really stop the bleeding, but it really it allows for the process of hypovolemia and all those kind of things to kind of retard. We're also going to review the actual placement of the garment, because there's a certain way that you have to put it on, as well as a certain way you have to take it off. And so I think for me, that's all I have to say.
Okay, thank you very much, Dr. Gwen. Oh, thank you very much for the great introduction here. At least we have some background of what we can discuss and what we can build on from the discussion. So I know Dr. Gwen just started and give us that background. So for Dr. Mugaru from Mwananyamala, can you try to give us the idea of what you guys do at Mwananyamala? When you get a patient, how do you define, first of all, your postpartum hemorrhage how do you know which patient, if they identify the patient? So as a doctor, what do you do preparation for prevention of that postpartum hemorrhage? And then which ones are your risk factors for these patients, and how do you go about it? If you can give us a little overview. Dr. Mugaru from Mwananyamala. We are waiting for Dr. Mugaru. Then Mr. Kamana, can you give us the idea of Muhimbili? What are the criteria for, first of all, how do you define a postpartum hemorrhage, and what are the criteria for screening of these patients, and what are the risk factors that you identify maybe for the nurses to monitor if the patient comes in preparation for postpartum hemorrhage? Mr. Kamana?
Yeah, yes. Yeah, the idea here at Muhimbili National Hospital, when the patient comes in with such diagnosis or is pregnant and developing such kind of situation, we still define PPH as blood loss above 500 mils when a woman delivers by CVD, and 1,000 mils it is by cesarean section. So the idea here, when we meet the situation like this, we normally call for the emergency. You know, this is emergency. We shout for help, then management for postpartum hemorrhage that comprises of sure that the cannulas, IV lines are patent, catheterization. Then while we are dealing with this with the emergency, we normally find the cause of the PPH, and after we find the cause, we treat accordingly. If it is trauma or it is uterine atony, we treat it accordingly by giving some medications that like oxytocin, and so that to make the situation stops.
Okay, thank you very much, Mr. Kamana. I know the audio was a little bit off in the between, but I think we have an idea of what you were just saying. But so if as a nurse comes, the patient comes in Muhimbili, do the nurse have the criteria somewhere is written, or everybody, it should be understood that, okay, if the patient comes in, has A, B, C, D, then I need to worry about or preparing for potential postpartum hemorrhage after the delivery? Like, as you said, giving an IV or notify provider. Do you have it written somewhere else, or it's just it's understood for everybody who is taking care and labor and delivery?
Yeah, here in Muhimbili National Hospital, there is every place where delivery is undertaken. For example, in labor ward and pre-eclampsia unit, here and theater also, where delivery done, there are some criteria, SOPs for managing the patient with the postpartum hemorrhage. So they are there. Actually everybody is aware of what should be done when a situation like this comes in.
Okay. And does every patient get an IV access or no when they come in? A pregnant patient who is in labor, or schedule, scheduled C-section is going to have an IV, but a patient is scheduled for, is coming in labor. Do those also get an IV, like do labs work and stuff? So anesthesia, we have something to make the recommendation from.
Normally here in Muhimbili, they have already cannula and catheter, because these are the protocols before transferring the patient to our hospital.
Okay, thank you very much.
Oh. But if someone develops PPH, we need to have more cannulas so that to make easy to make easy patching to blood and the fluids that we need to eat. So, but for this case, if the patient before coming to Muhimbili National Hospital as the referral protocol should have catheter and cannula already, unless if she comes from home or elsewhere.
Okay. Okay, thank you very much. Dr. Emma, in North Carolina, if you get this patient, first of all, how do you define the postpartum hemorrhage? And then how do you screen for them? How do you prepare for that patient? And also, what are the risk factors that you identify for you to alert you that this patient might be at risk for postpartum hemorrhage?
Okay, yes. So our definition is similar to what Dr. Gwen said earlier. We use the new definition where we say if somebody has had 1,000 cc's or more of blood loss during a vaginal or a cesarean section, and also if they are having symptoms of blood loss, low blood pressure, increased heart rate, things like that, that is a postpartum hemorrhage. So we do use the new definition. And just like Dr. Gwen said, when patients come in, we do a thorough history and physical exam to identify what risk group the patient is in for postpartum hemorrhage. And so we do have this protocol that's in the hospital that the nurses and the providers adhere to. And so when you look at the list of the patients who are admitted on the floor, right next to each patient's name, you're going to see which group this patient falls in. Is she at low risk for postpartum hemorrhage? Is she at medium risk? Or is she at high risk? So it kind of says clearly in the board that everybody in the unit has access to. And so if they're in the low risk group, assuming that they don't have any risk factors, they've never had a C-section, maybe they just have one baby, they don't have any prior history of postpartum hemorrhage, those are the patients that will get like a type and screen on admission for all of them, even if they're in low risk group. And of course, prevention is still key. Even though they are technically at low risk group, we do know that it can happen to anybody, even in the low risk group. So this group of patients will also get Pitocin after delivery, just as a routine. So the nurses know as soon as the baby is delivered to go ahead and just start Pitocin. If they are in the medium risk group, let's say they've had more than 4 deliveries before, maybe they've had more than 2 C-sections before, they are maybe obese, maybe the baby is large, they have uterine fibroids. These patients will also have a type and screen on admission. They will also have the Pitocin prophylactically. And then you want to discuss with the patient just to give them a heads up, hey, you're at medium risk. If we have any evidence of postpartum hemorrhage, we may need to do additional things in that emergency situation. So just also prepping the patients, we'll do a little bit of that for the medium risk group. And then if they're in the high risk group, let's say somebody has a placenta previa or placenta accreta or suspicion for abruption or any of those coagulopathies, then they're in the high risk group. And these are the patients that you definitely want to go ahead and cross match them for blood. And they will definitely get the Pitocin, of course, after delivery. But also, you probably want to observe them much longer in the unit as opposed to the usual standard, maybe 2 hours after delivery. You probably want to keep them longer, like for at least 4 hours or so. So that's how we do it. And like I said, prevention is really to give them the oxytocin immediately after delivery. We usually give them IV. And the nurses are aware of the orders for that. They will usually get a bolus, and then they will they'll continue to run it for a few more hours after that. That's what I got for you now.
Okay. Thank you very much, Dr. Emma. Yes, we're gonna come back and get more from you. So Mr. Bashir is not online. He's from Buguruni, so we wanted to know what Buguruni are doing, but I guess we are not going to be able to get that because he was not there. And Miss Neema, who also was from Buguruni, she had a small emergency, so she has to go. Dr. Mugaro, are you back from Monanyamara? Or Dr. Benera, if you're still there?
Hello.
Hey, thank you for coming. Go ahead.
Yes, sorry for joining late. I had some other issues I had to do.
Thank you.
But thank you for the opportunity to join you today. According to the questions that I was hearing the former contributors answering, at Mwananyamala, whenever we get a pregnant woman that we have to admit, we usually screen their risk factors for PPH. So in case any woman maybe has a big baby, twin pregnancy, hydramnios, or anemia, or previous history of PPH, we usually order, or pregnancy-induced hypertension, we order them, we usually order some uterotonics just in case they deliver and get PPH. So the uterotonic that we usually use is misoprostol, apart from the oxytocin that we use from the management of third stage of labor. We use misoprostol, so we order misoprostol, and misoprostol is there in standby. We also order tranexamic acid in case the patient develop any coagulation issues. Yes, thank you.
Thank you very much, Dr. Mugaru. In fact, the next session is going to cover the medication, but I'm going to bring back Dr. Emma. I know she mentioned something, we screen, she screens her patient and make sure all the labs and notification is done. Is Mwananyamala does the same thing? Like, do you have like anesthesia standby? So if you get information, then you can share with anesthesia there, or does the anesthesia comes and see that patient when you guys are doing like intake or admission there, so they are aware of the potential person who might be at risk for bleeding? Dr. Mugabe?
Yes, here, so it depends on when the mother presents. For example, if she comes and she's already in labor, so she goes to labor ward. As soon as we detect that the woman is going to get PPH, we usually have the theater standby at 24 hours. So, and the anesthesia is usually available. So whenever we get PPH case, the anesthesia is ready for review and we send the patient to theater.
Okay, thank you, excellent. Dr. Gwen, do you have any question for Mwananyamala or Muhimbili for things that you have discussed on your introduction of the, like the postpartum hemorrhage? Do you have any questions for them? Something
no, the only question that I had is, do they have, I know Dr. Emma probably does for sure, but do they have teams that are readily available? When a patient comes in, or do they have to assemble a team, or how does that work initially?
We can start with Mr. Kamana.
Because essentially time is of the essence since we have so many other factors that we have to deal with.
Yes, pardon, sorry.
Yes, Dr. Gwen is asking, do you guys have like the team ready? Let's say you start the shift. Does everybody know that just in case if we have postpartum hemorrhage event, do we have people who are ready to know, okay, I'm going to be the scriber, I'm going to be the runner, I'm going to be this? Do you have those people identified beforehand? Or when the event happens, you call for help and then people show up? You hope they show up with the right skills.
Yeah, Yeah. Here we have a team. We have team on call. There is nurses and doctor specialists, and then goes down to, so when some for help, it starts for the nurses that are
Your phone is cutting off.
there. Then registrar, residents, and clean. And do you hear me? Yes, do you hear me?
Now I can, but can you repeat what you just finished saying the last time? Because yeah, we couldn't hear before, but go ahead now.
Yeah, I was trying to say that here every day there is team on call, which comprises of nurses, residents, registrars, and specialists that all are readily available anytime. So if anything happens, we start with all these are readily available, and if something need for the anesthetist, anesthesiologist, that later on anesthetist will be involved. But for the time being, if something happens in the labor ward, everything is managed according to the respective team.
Okay, thank you very much, Mr. Kamana. Dr. Mugaru, I know you mentioned a little bit some of the medications, so can you just go over it, again one more time? What medication do you use during the event, and why did you choose those medications?
At our setting, the medications that are readily available for PPH is first oxytocin, that we also use during the management of third stage of labor. But apart from oxytocin, when the uterus still doesn't contract, we usually use misoprostol, prostaglandin. But we can also use okay, apart from that, we usually use tranexamic acid for coagulation to help speed up the coagulation. Other than that, we have blood, where we have whole blood and fresh frozen plasma, and IV fluids to expand the volume, ringalactate and normal saline. Yes. Thank you.
No, thank you very much, Dr. Mugaru. I'm going to bring back Mr. Kamana. What is the medication you use? And then we're going to go back to.
Yeah, here at Muhimbili, it's not quite different as Mwananyamala. We always use oxytocin for the active management of third stage of labor, or if the cause of PPH is uterine atony, we usually use oxytocin and misoprostol also. Misoprostol is another medication that we always use, and tranexamic acid for coagulation. Yeah. Also, we have a plasma expander. We have these fluids, ringalactate and normal saline. Yeah, blood we always use for the management of PPH. So it's not different like Mwananyamala does.
Okay, thank you. I'm going to have Dr. Emma Mugeri go that, and then Dr. Gwen is going to give us that part, and then the massive transfusion protocol too, just to go over it. Dr. Emma, medications that you use for postpartum hemorrhage and why?
Yes, we do have all those options that have been mentioned by our colleagues from Muhimbili and Mwananyamala, I believe. So all those options, but also we have something we call Methagine, which is an injection that they could get intramuscularly. So that is actually more for like if there is postpartum hemorrhage and let's say you're doing the oxytocin and the misoprostol and maybe it's still not working, then this is a third option called Methagine. And you could give it IM, 0.2 milligrams one time. I'm not so sure if you guys have that in Tanzania. And however, it is contraindicated if somebody has a history of high blood pressure, because the Methagine can actually increase the pressures even more. And then the other option that we have is called Hemabate. I think it's also known as carboprostromethamine. And this is also an IM injection that can be given, especially if the oxytocin and the Cytotec is not working. And let's say somebody has preeclampsia or high blood pressure and they cannot get the Methagine, then the Hemabate is usually an option for those types of patients.
Thank you very much, Dr. Emma. And then Dr. Gwen, if
Dr. Emma, can you just explain them? Like, we kind of use those drugs pretty soon. We don't like wait for a long amount of time. Can you just kind of identify to our colleagues like what your criteria is and how quickly you use it? Because a lot of times, especially if the patient is bleeding, they'll just ask us to give that, right up front rather than waiting down the line. So do you have any kind of criteria that you use in terms of time when you give Methagine or Hemabate?
Thank you. Yes, so definitely time is of essence in these types of situations. And so I would say when the patients are not responding to oxytocin, the uterus is not firming up. I mean, you are ordering that misoprostol immediately.
Right.
So we don't really wait. I mean, it's like you give oxytocin, is the bleeding subsiding? Okay, you can continue with the oxytocin. But if she's still pouring out blood, you're ordering the misoprostol, you're ordering the Methagine. So I would say it's a matter of like minutes. Yeah. I don't really think we have like set times, like, okay, wait 2 minutes, then give something else. Like, you are calling these orders, and if it's not responding, you're calling for the next one, essentially. So time is of essence.
Yes. Yeah.
And I also want to add that if somebody is, for example, in the medium risk group, depending on the provider, some providers will actually order TXA, for example, from the get-go. Like, okay, you've already told the nurse, as soon as the baby's delivered, give the Pitocin and give the TXA, or even give the Pitocin and give the misoprostol, like just prophylactically, because she's in the medium risk group or high risk group, and you want to be sure that you're on top of everything.
Yeah, good, thank you.
You're welcome.
Thank you, Dr. Gwen, for that follow-up question. Just to add it, as the nurse, usually in a unit, we have what we call the postpartum hemorrhage kit, which you always have those 4 medications for us, the oxytocin, misoprostol, Hemabate, and Methagine. Of course, we keep it in the refrigerator. So like what Dr. Emma just said, yeah, as soon as it's identified right then and there, we see Pitocin is not working. Most of the time we call the code and everybody comes. So there'll be probably 2 or 3 nurses. One is giving this shot, another one is giving another one, just because we don't wait and to say, okay, let me see if she's gonna progress. So probably if she's bleeding within 5 minutes, the patient might have all those 4 medications right then and there. So we're not going to wait and see, let's see if this works or doesn't. And I mean, majority of the time, if you do that, it's going to prevent or slow down the bleeding, and then of course firm up the uterus. Hopefully the uterus is going to work. On top of that, if somebody is already there at the with the moms doing massaging the fundus like a continuous, while the other people are giving meds and IVs and all the stuff. So things are done almost within 5 minutes. All those things have already been done. Of course, identify those risks for hypertension. Then you worry about the Methagine, or asthmatic patient, you worry about the Hemabate. So all those things are done simultaneously. Within a few minutes, the patient might be better off instead of waiting for one medication to work or the other. So thank you very much, all of you, for contributing for that medication. Dr. Gwen, anything about the massive transfusion, just in case if those medications are not working, what can we do with a massive transfusion from your experience?
In terms of protocols?
Yes.
Oh, yeah. So essentially, you have these massive transfusion protocols that are readily available. So I think one of the issues when we talk about the massive transfusion is the having the blood and other products available. If you don't have blood, then essentially the only thing you can do is transfuse these patients with crystalloid, and then crystalloid just kind of buys you some time. But at the end of the day, when you talk about massive transfusion, you really need to have blood readily available, okay? And so that is, if the patient is bleeding and the patient hasn't responded to anything, basically you're putting in a line, you can put in an essential line, you can be doing all those kind of things to keep on top of it. We also have some ways now not to actually go invasive, but to be able to monitor things with these patients without putting in A lines. I'm sorry, without putting in central lines these days. Okay, mass transfusion protocols, they should be in effect. And I guess I would want to find out, do they have mass transfusion protocols in Tanzania? And if they do, when are they implemented and how? I guess that would be my question, if they have those kind of protocols, since they don't really have blood available.
Dr. Mulungu, can you help us with that?
Actually, we want to introduce that the protocol we had now these days. We have some countries are using there is so-called massive blood transfusion protocol. In our country, actually, we don't have massive blood transfusion protocol, but we know what to do. What we are normally doing, for instance, the patient will be given fluid, will be given fresh frozen plasma. For instance, in Muimbili, it was difficult to get blood products like platelets or you know, even blood itself sometimes was problem. You know, in Tanzania, for a woman to get more than 4 units, you must be lucky if you are bleeding. You must be lucky. You know, we rarely get more than 3 units. You see, if someone is bleeding, because, you know, everyone needs blood. You see, and patients are coming, so many patients, and our blood bank cannot, you know, carry all that burden of Dar es Salaam patients who are coming for bleeding, you know. And as you know, you have patients who are planned for elective surgeries as well. I'm not saying that blood which was kept for elective surgery will not be used for emergencies. It can be used. But what I'm trying to say is we are just giving what, you know, if the patient has lost volume, we'll replace with crystalloid. Crystalloid is very easy to use. And, you know, in anesthesia, we say use more crystalloid fluids than using these colloid fluids. So we are giving fluids, we are giving fresh frozen blood, you are giving blood if it's available. If platelets are available, fine, we'll give platelets. But we don't have a protocol. But my plan is to have, when you are coming here, then we'll discuss and having that protocol and try to implement that if it would work in our setting. You know, the problem, what is frustrating us is lack of, what is frustrating us is the availability of blood. Sometimes we don't have blood or blood products. So if you have 6 women, some are coming from Temeke, some are coming from Mananyamala or Amana, all are coming together, you're going to be in trouble to get to serve them all at a time. You see, so maybe the first woman will use all the blood which is available for. And sometimes we are having problem of some of the blood groups are really very rare, like O negative blood. In Africans, I think it's a problem to get people. I'm not sure, I've not done any study, but if someone is O negative, to get someone, you know, blood to get O negative blood. For instance, you know, O negative can be safely given in many of the patients, as I understood. But, you know, to get someone who has O negative, there is issue of giving O positive. Can it be given? Will they, you know, many people will like maybe can be sensitized in, you know, patients like this, you know, these results in compatibility problems, you see. So we are having problems of getting blood products just to be short. And we give what we have. But giving fluid has no option. If patients has bled profusely, there's no choice. You have to give plenty of fluid. But plenty of fluid does not carry oxygen. You sometimes have, if there is patient in shock, you also need to give blood. That's what we are doing here. And we'll soon, maybe I'll try to talk to my colleague, the head of gynecology, and trying to see if we can have a massive blood transfusion protocol. And when you are coming, and I'm sure you'll help us to give us idea if this is what we have, what we're gonna do. And if we can try to use our own sort of massive blood transfusion protocol according to what we have here. That's what I can say. Thank you.
That's
because a massive here, when we talk about massive transfusion protocol, it's almost like a trauma. And so we're talking like patients getting 10 units. They come with a 10 pack and that's what they receive right up front. Now, do you guys use TXA as if you only have 2 units of blood available and you give the blood to the patient, are you using TXA as part of
what is TSA? What is TSA?
Tranexamic acid?
Yes, we give.
I'm sorry?
Tranexamic acid we give.
Okay.
We give IV fluids. We make sure that the patient has IV large ball cannulas, both hands. Okay. We infuse them with plenty of crystalloid solution. Then tranexamic acid will also be given. Okay. Okay. Then fresh frozen plasma will come in. Okay. We give them. And then if blood is available, can also be given. We are just, trying to save these patients.
All right. Okay.
Yes. So training in the past, we used to give ergometry. You remember this drug is very old drug.
Yeah.
It's known as ergometry. But because of the side effects, now we are no longer using ergometry. Have you ever heard of the drug which is known as ergometry?
No.
Yeah, when I was starting my training, it was available, but now people are discouraging using of ergometry. It has the effect of generalized vasoconstriction, and also it increases uterine tone. So because of these side effects, so that's why we are no longer using it.
Okay.
And we don't have the drugs, as you said, like Methagine, and what was it? It was this Hemabet.
Yeah.
Yeah, these are the drugs we don't have. We are mainly using oxytocin, which is right. We are using the word which is known here is oxytocin, and misoprostol, as my colleagues have just said, that misoprostol, and there is no better drugs than that, than these two. So misoprostol, oxytocin, or both.
Okay.
Okay.
Yes.
Now that's good. I mean, I think you provided and raised the great questions.
Yeah, and the problem here in Muimbili, we are having two groups of patients. There are those who are elective patients who have been admitted, and anesthesis will usually be involved when the patient is planned for surgery. And I was a bit surprised when I heard that patient who is I think in America, any patient who is at risk, anesthesis will be involved. But here, anesthesis is involved only when the patient is planned for surgery. So maybe, and it's an elective case, and it's an elective. So this patient, the day before surgery, will be, after a list of patients who are planned for elective surgery, then the anesthetist will go and see this patient to see if there is any comorbid or, some airway problem or something like that, and prepare. But another group of patients are those patients who are coming here as emergency from other hospitals or from within hospital. For instance, patient who was elective vaginal delivery, or, and then developed postpartum and develop perineal tear, okay, 4th degree or what. So may come to theater to have a perineal repair or vaginal repair or something like that. So these are the problem we are facing. And even the way I think you have been here to Muimbili has to be transferred. This is a very, and even the construction of the hospital, the patient has to travel from the labor room to theater. You understand? So from theater to is a bit long way, has to go via
did we lose him?
Yeah, I think so.
No, that's okay. I think that's a good point he raised about reviewing and working to try and see if they can do massive transfusion protocol in Tanzania.
Right.
Then you can address it.
I guess it would be modified because they don't have.
Yeah. You have to modify for us.
Yes.
And see if it will work, and try to introduce in the Department of Obstetrics and Gynecology and Anesthesia. We have to discuss how we can do together, and then have a very good protocol according to our setting here.
Yes, definitely. That will be one of the areas that I'm going to ask Dr. Gwen to be able to spearhead it. And then we're going to still communicate. And that's why we're doing this training, because we want to make sure we learn this area that we can work together and improve. And definitely, a patient with experiencing postpartum hemorrhage is not a one department concern. It's every single person, starting with the labor and delivery nurse and OBGYN, anesthesia, pharmacy, also, of course, all these drugs, when you're giving them so much, we need to be able to remember and reconciliate with what medication she has been taking before, and then offer them that, or their pre-existing condition. I'm going to let Dr. Emma, I know she raised her hand for a while. Dr. Emma, you want to have something, and then we go to the case study? Dr. Emma?
Just a quick point. I think the other doctor said something, some medication that's an ergonomic. I didn't really get the full name.
Ergometrin.
What?
Ergometrin.
Ergometrin.
It's an old drug. We are no longer using it.
Gotcha.
Ergometrin.
Okay, I was wondering if that's similar to the Methagine, because the Methagine that we use here is an EGOT derivative. It's an EGOT.
Yeah, it's
Yeah. Okay. So
I have to find out. If it's the generic name is Ergometrin.
Got you. Yes. Okay, that's interesting.
For instance, yeah.
But yes, it can increase your blood pressure, so we always avoid it in people with elevated blood pressures.
Okay, and I think Dr. Msambichaka raised her hand, and then we can go to the case study. Dr. Msambichaka?
Thank you so much for allowing me to ask this question. The question that I have, I guess it's an ask for Dr. Gwen and Dr. Mugari, is I know there's centers in this country that have maybe bloodless transfusion protocols, especially designed for the Jehovah's Witnesses.
Jehovah's Witnesses, yeah.
And so I was wondering, like, if maybe through your network or like your listserv, if you could ask to see, like, what do those centers do for patients that are Jehovah's Witness that, you know, cannot receive blood but still need some resuscitation? Maybe they have protocols in place. I'm thinking that might, like that with the modified protocol that you might do for Tanzania, might actually work out, maybe like as a blended protocol might work out better for Tanzania, given the lack of available blood.
Sure. I'll take a look at that.
No, thank you very much, Dr. Msambecheka, for that great suggestion. Yes, that could work, because if you have the revised or improvised massive transfusion for somebody who cannot use blood, which could work on the limited resource area. So thank you very much. Okay, I'm going to go over the case study. Ms. Neema Mushu was supposed to present this case study. Unfortunately, had another, she has to be somewhere else at this time. So I'm going to read what she presented. This was happening from the Kinguguti. The patient was 24 years old. Date of arrival was the 25th of May, and she arrived at 15:30. She was 40 weeks, G1 P0, no abortion. Last menstrual period was 19/8/21, and then the EDD was 26 of May. So vital signs on admission was 120/80. So heart rate was 100, and respiration was 18, and the temperature was 37 Celsius. And she attended, I think, as antenatal clinic. So at 15:40, the examination was done. The cervix was assessed, and it was 4 centimeters. Fetal heart rate, so fundal height was 34 centimeters. Contractions, heart rate of the baby was 142 beats per minute. And then, of course, the cervix was soft and thin, and continue monitoring in labor. So they did an investigation in which hemoglobin was 10, and then the blood group was O positive for this mom. And then so the examination done again at 1900. The cervix was 8 centimeters, level 2 or 5. I'm not sure what is that. Maybe our colleagues in Tanzania will help me with that. Contraction was moderate, and then every 3 minutes, the heart rate was 120, and membrane was ruptured, but meconium was present. So what they did, they managed this patient by running fluid, directed Lingers, 2 liters. They did catheterize the patient and continue monitoring the labor. And then at 20:30, mother delivered a male baby by vaginal delivery. Baby weighed 3.3 kilos, and then score is 810. So I'm assuming that's the APGA, like 810. And then oxytocin was given 10 units IM, and then within 1 minute with the delivering of the placenta. And then the massage the fundus. And then mother also developed excessive bleeding. Estimated blood loss was 2,000. And then the second part was that they call for help, which we discussed about those having the teams ready to go. So if you need the help, then everybody knows their role. So they call, they mobilize the resources, and somebody was there psychologically supporting the mom. Of course, you know, anxiety is going to increase the bleeding. Anyway, fluid was given again, 2 liters of lactate ringer, and then 4 liters of normal saline. Indoor catheter was inserted. Oxytocin 20 units in a liter was given. I'm assuming it was given bolus. So those intervention continues, and then the massage, the uterus continues, but blood, the clots still was there. The uterus was not contracting. So the cytoteco, the misoprostol, was given 800 microgram by mouth, and then the TXA 500 was given IV. And then additional oxytocin was given up to 60 units, and continue massaging the uterus. I know there is a protocol specific, at least for US, how much you can give Pitocin for how long and why, because sometimes if you give them too much, it might be excessive. But then the uterus still did not contract very well, I'm sorry. So they decided to use the balloon for the uterus, and then it's the balloon catheter, which is the Foley catheter, was inflated with 50 cc of the water, and they remained there for 24 hours to help with the hemodynamic. And then so the fresh frozen plasma was given 2 units. Also, so fresh frozen plasma was given, and then 2 units of O positive was given, and the whole blood of 2 units also was given. They did give her the patient antibiotics. So amplicross 500 for 5 days, and then Flagyl was given 400. And then vital signs, probably at the discharge was 110/60, temperature was 36, pulse was 120, respiration was 20 breath per minute. And then they continue closely monitoring this patient after 20. The hemoglobin increase was 9, and then the patient was discharged home 3 days later with the ferrous sulfate, and she was supposed to take for a month, and then folic acid 5 milligrams was supposed to take also for a month. So this case study was shared with the contributors. So I know I was reading a little bit faster, but you have seen this case study at least for few hours. And then, so what is your feedback? What are the things that was done, which as far as your practice continue with that, or if there's something else they could have added to this patient, or something that maybe they did do, which in your practice you may not be able to do that. We started with.
I would have to say right off that in terms of the amount of oxytocin that was given up front, I think that it wasn't an adequate dose. They only gave the patient 10 units initially. And so that could have been one of the problems, I would say, because we usually give 40.
Yeah, so initially I think they gave the 10 IM, and then there's a 20 units they put in a normal saline, and then they gave up to 60 units added. So the total of 70.
Go back to the first slide. Yeah,
initially, I don't know if you can see my little cursor here. So here they started with 10 units IM. Yeah, and so next page, they gave on management, they gave 20 units in a normal saline IV. And then they say when they're doing the management, and now they are doing the interventions. When they call the help, they give the 20 now IV. At the delivery, they gave IM. I'm not sure about the time spanning from the IM to 20 units of.
Right. I'm
not sure about the time. And then additional, they added 60. So the patient had 70. I'm not sure. So again, this span of time, what was given. But that would be a good question to ask if Ms. Nema was here, unfortunately.
Because if you think about it, if you're giving something IM, the onset of action is certainly not going to be that as IV. So you're kind of losing time with the IM versus the IV. Dr. Emma, would you agree?
Yes, I would agree. I believe the IV option is definitely faster acting, and also you can give more of it. Here we usually give up to 40 units at a time. But I think with the IM, I think the recommended dose, however, is 10. So I do believe if that's not working, you probably want to switch to IV. But I do believe that that's the recommended starting dose with the IM approach.
I'm going to have Dr. Mugalu. How is the process in Mwananyamala? If you had this patient, and you can just give us a tentative time in between the dosage of the Pitocin or oxytocin, how would you manage that? Mugalu?
At Mwananyamala, yes. When we are managing the third stage of labor, we usually go with the 10 international units IM. And then as per this case, when the patient developed due to uterine atony, we would give them up to 40 international units, 20 in
sorry, Dr. Mugalu, yes. I think, sorry.
Okay. After the misoprostol, because this patient was bleeding due to atony, we always do aortic compression so as to stop blood going to the uterus altogether, so as to reduce the blood loss. As we saw here, she lost about 2 liters. Here yes. We have the practice of doing aortic compression while massaging the uterus, while ballooning and other forms of management is going on. Thank you.
Thank you. So, for example, when you said you routine, you start with the 10 international units of Pitocin IM, and then of course, if they realize, because I mean, you have to have some time to see the blood is coming out within, I don't know, 2, 3, 4 minutes, I don't know. And then so they start the IV. So the 20 units and then the 60 units, as I said, unfortunately, Ms. Neema was not here. But usually if we were giving and we decided the 20 units is not enough, how long does usually, on your practice purposes, how long does usually you think it will take for you to start from 20 to go to 60, if this was a patient?
At our practice, after we give the 10 international, as soon as the patient has delivered the baby, we give the 10 international units, and then we do the active management of the third stage. After the removal of the placenta, we assess the tone of the uterus. So if the uterus is still atonic, it's usually about 5 minutes since delivery, and that's when we can discover this patient has PPH due to atony. The uterus is not contracting. We go to the 20 IV and 20 IM.
Okay. Okay. Thank you.
I just have a question. Is there a particular rationale for giving IV, for giving IM versus IV if the patient has access?
Please come again.
If the patient has IV access, what is the rationale for giving IM versus IV?
You can give either IV or IM. I think it's just our protocol that IM is easier because we could still be doing preloading to the patient. You know, after delivery, they lose some blood. So we go on with IV infusions, because if you give the 20, you will have to titrate it. But as per here, we give the IM so that you can go on with fluids while we have given the oxytocin.
Okay, I'm looking at this case study again. So as of, I mean, from what Dr. Mugaru just explained, the oxytocin is 10 units, 10 international units is given with the delivery of the placenta. So that is the routine before the patient realize that the patient is bleeding. So that starts like a standing orders almost all the time. When the patient is delivering, before you get the placenta, you get the 10 IM, which give it not a few minutes to go and contract the uterus and the placenta is out. After that, then they give that 20 units within 5 minutes. So that almost like within 5 minutes, the patient had the 10 IM and then the IV. So even if the patient has an IV, I think they're giving that 10 international units with the delivery of the placenta. So that time the placenta can be delivered from the baby to placenta, maybe 5 minutes, maybe 20 minutes. So it depends. I know we have another Dr. Nestori from Sweden. I know he had some feedback. Go ahead.
Hello.
Hi.
Yes, I think Dr. Mugalu has already explained about the protocol in giving this oxytocin after delivery. But I was like, yes, I was also having the same question that Dr. Gwen asked about how was this oxytocin given? Because I have been working also, I worked in Tanzania before I just moved to Sweden to work here. And we normally don't have a very, very systematic protocol. Like we can give this, it is written in our guideline, we give the oxytocin, like the 10 international unit, and then you can give concentrated oxytocin in IV fluid. And about the exact, normally the midwife, they can calculate how many drops and how many milliliter per hour, like 120 milliliter per hour. And then if the uterus has contracted, then you decrease the dose, maybe to 60 milliliter per hour in that form until you you phase out the oxytocin. So that's about the oxytocin management during labor, during delivery or after delivery. And so I don't have a lot to add in that, because mostly the midwife, they are responsible in giving the oxytocin, and they know exactly how to do the management with the oxytocin. So we normally don't like mix this like concentrated oxytocin. We don't mix this maybe what I can say, maybe 8 international units in 500 natrium chloride or ring acetate. We don't mix it. Normally the midwife, they know better how to mix and how to provide to the patient. We normally order. That's the management, but it is in the guideline. It is clear in the guideline, in our Tanzanian guideline. It's also clear how to give this oxytocin. But I don't remember it exactly in head.
Okay, no, that's great. Thank you very much, Dr. Nestori, all the way from Sweden, and thank you for coming to our training and share your practice there in Sweden, and you have a history from Tanzania. I know that a couple of people raised their hand. Monanyama, I think, raised their hand, and then I think somebody else was Sadan.
Yes, Sadan.
Yes. Sadan, if you can say something, and then Monanyama is going to be, and then we will go to the next case study. Is that sad person known as Sadan still here?
They're muted.
Oh, Sada, you're muted. If you're speaking right now, you're muted. Sada, no? Okay, Monanyama, go ahead.
So thank you for the opportunity. I had an addition on the management. Like I think from the start, when after realizing that the uterus is atonic, we also need to rule out other causes of atony. So retained products may cause atony. With the interventions that has been mentioned, most likely it took a lot of time or a lot of efforts to achieve the tonic. So one of the important things also is to rule out other causes of the atony, most especially the retained products, cervical tears cervical tears. So which will minimize the use of rushing to using a lot of oxytocin or a lot of prostaglandins, like how we use misoprostol. So in other cases, you'll find when you delay to realize the real cause of the atony, you may think it's just the uterus that has failed to contract, but rather there are other causes. So I think that's a note that we should always look before going just for the tonic agent. Yes.
That was an excellent point, Dr. Mugalu. I agree. Yes, there's you can see a number of interventions that were done. So definitely, we all know in labor and delivery, when you are doing, like getting the placenta out, that it might take another minute or so, massaging the fundus sensor, calling for the cord, calling for this. So those time it's going to be added to what the care is given. Yes, the goal is to do immediately, and then like combine some of the interventions, having more people, so then you have different roles. Like if I come in, okay, you are the medication administration, then you can give the medication while somebody else is trying to work on the balloon because they're trying to try to stop the bleeding and inflating and doing all that procedure. So you have to have more than one person to be able to do those things. So I appreciate all the feedback for that case study, and I know probably there's a lot of things that still have to be discussed on this area. I know Mr. Kamana are you still there, Mr. Kamana? Oh, we lost him somewhere.
Dr. Mulungu.
Yeah, I was going to give Mr. Kamana and then Dr. Mulungu. But if Mr. Kamana is not here, Dr. Mulungu, go ahead.
I wanted to ask Dr. Gwen. I'm sorry if I did not I've not pronounced the name properly. Dr. Gwen, talk about the drug which was given intramuscularly.
Yes.
During the massive transfusion protocol. Which drug of that? And my worry is when the patient is a bit underperfused, that drug may not be taken. But I'm sorry if I didn't hear properly. Were you giving one of the drug intramuscular when performing the massive?
No, in a massive transfusion protocol, we do not give anything IM.
Transfusion. You give IM?
No, we do not.
No IM?
No.
Okay, thank you.
Mm-hmm.
So my worry is when the midwives in our country, if someone is bleeding, is underperfused, giving drug intramuscularly will not be taken very well. And it may be, yeah, why don't we just, the problem with oxytocin, it has side effect. If you give it so fast, it may cause a bit of hypotension. So I think that is the worry. That's why they start with intramuscularly. And then, but what I've just understood is that they give before hemorrhage. If patient is bleeding, I don't think that they give intramuscularly. I'm not sure. They can elaborate that.
I mean, in the States, no, we do not. And basically, you're talking about 5 minutes with the onset for the IM, and sometimes you don't have that amount of time. So we don't routinely use IM drugs here. If the patient needs it, the patient has an IV, and usually it's given IV. So we put 20 or 40 in the bag, depending on whatever the OB thinks at that time. But no, we don't use IM.
Dr. Emma, I have a question because I remember my days at the bedside. We used to do the 10 international units with the delivery of shoulder. So that was practice after a while, and then of course it was changed, but we used to do that. So that part, we have not identified the patient as active bleeding, but no, just the preventative measures. Or when we had this patient with midwife, they wouldn't want the patient with a running IV. So then we do IM with the delivery of the shoulder. So before the placenta, the baby's head comes out, they're trying to give it, but it's going to take maybe another minute for the medication to be absorbed completely. So then probably by then the baby's out, and then they want the placenta to come out quickly because the uterus is contracting. So I remember that practice, we used to do that 10 IM before we do the IV. And by the time we get the placenta out to start seeing the bleeding, then we open up the bolus, and then we continue whatever we have to do to manage the PPH. Mr. Kamana, you came back?
Right, but he asked about and if IM is used in massive transfusion protocol, is what his question was.
Is he talking about the Methagine that I was asking about, the EGOT derivative? If that's the case, I would say that's usually used like in the early stages when it's starting out, when the postpartum hemorrhage is starting out. You've given the Pitocin, oxytocin, it's not working, the misoprostol not working. Next, then I would give the Methagine. So at that point, I don't think they're really hypoperfused. We're talking about the first like 10 minutes of postpartum hemorrhage. That's when I would use the IM Methagine. But when you get to the massive transfusion, it's all IV at that point. You're giving the blood products, the FFP, the blood, the cryoprecipitate, it's all IV.
All IV, yes.
Okay, thank you very much. Mr. Kamana?
To add on the previous discussion that in our setting, IV IEM oxytocin is used as an active management of third stage of labor for prevention of postpartum hemorrhage. And IV infusion is always used as a treatment for postpartum hemorrhage after PPH has occurred. So we always use infusion oxytocin just to as a treatment for postpartum hemorrhage. But IM we usually use as a prevention for postpartum hemorrhage as part of active management of third stage.
So you just use it prophylactically, period, in all cases.
Okay, and I do have a question. Do all the patients who come in labor and delivery, Mr. Kamana, do they all have IV access, or is it select patients that get IV access from the beginning?
From the beginning.
Does everybody
Yes,
get IV access?
Yeah, yes, in the labor and delivery, not all the patient has an IV access.
Okay,
but
so
here at Muhimbili National Hospital, labor, delivery, it can be held in the unit or every patient has an IV access. If she delivers and get
okay, I think no, so not every patient has an IV access.
Okay, so I wonder if that's why they start with the IM, because if they don't have IV access from the get-go, you definitely want to go IM, and then as you're maybe working on IV access. So probably that's why I'm thinking that they start with IM, especially if they don't have IV access.
Okay, all right.
Yeah, okay, so moving along. So if just in case if this patient was not able to be managed and need to be transferred, so we Buguruni have a protocol, which is just called Referral Protocol, and just itemized things that the nurse needs to do, like vital signs, cannulation, catheterization, delivery tray, and all the stuff. So those things, the nurse, escort nurse, we have ready to go when they need to transfer that patient. So the question usually came and we asked, how are we going to know what do we need to do when the patient is transferred? I know probably we answer some of the question that by then this patient has an IV, so putting an IV is already in place. And then what exactly does if the patient is transferred to Muhimbili, what exactly the Muhimbili does to receive this patient? So I have Mr. Kamana with this case study. Can you see it, or you can read it, or you want me to read it? All the contributors receive this case study. So, Mr. Kamana?
Yes, do you want me to read it?
Okay, let me read it and we can discuss this case. So Mr. Kamana provided this case study from Muhimbili. They had a 29-year-old who was transferred to their hospital using the referral from outlying hospitals, and with a referring diagnosis of the postpartum hemorrhage, eclampsia, and pulmonary edema. And the patient had this vaginal delivery several hours ago, and then outcome was the baby who was 1.5 kilos, APGA was 0.0 due to abruptio placenta. We all know and cringe when we hear that for labor and delivery. And then, so the reason for transfer was DIB. Mr. Kaman is going to give more information about that. And then reduced urine output. Estimated blood loss was 1.5 liter. And then from the referral nurse, the patient developed DIB after, and the developed increased urine output, and then so reported with the episode of convulsions. And then another episode happened when the patient arrived at Muhimbili. So the patient was not given magnesium sulfate. Upon arrival, the patient was given the methydopa 500 IV 5 liters, blood transfusion, I think 4 units. The fresh frozen plasma was given also 7 units for whole blood. Lasix was given 120 in the beginning, and then 60, and then other medication, the antibiotics and the tramadol was given. So when the patients arrived at Muimbili, patient was on non-rebreather, and then of course difficult breathing, no urine. Patient was conscious. I think Glasgow score was 15/15. Patient was not cyanotic. And then vital signs was 138, 1/106. Heart rate 138, and then O2 sats was 99. Non-rebreather was at 15 liters. Respiration was 32, and then the red blood glucose was 7.8. And then on the review the system, Mr. Kamana is going to continue doing that, but then the ABGs was done. So Mr. Kamana, do you want to give us a little background, and then people can provide their concern, feedback, and current practice on their own unit? Mr. Kamana?
Yes, hello.
Yeah, go ahead.
Yeah, this case was a referral from a regional hospital, one of the regional hospital here in Dar es Salaam. Patient came in with a diagnosis as indicated. Upon arrival, some information we are missing, and information that I have is from referral later, and the management of PPH before arrival. The patient was given IV fluid, 3 liters galactate and 2 liters normal saline. Then patient was given misoprostol, 1,000 in microgram, and was also given tranexamic acid, 1 gram start. Then IV oxytocin infusion, 20 international unit. Then the uterus was massaged, and then the bleeding cut off. But during the management of PPH that patient developed, the patient also had another condition. She started conversion. She conversed 2 times, two times. One in referral hospital before transfer. The other one during the way to Muhimbili National Hospital. Upon arrival to Muhimbili National Hospital, the patient bleeding was cut. Breathing within non-rebreather face mask. When she arrived, ABG was taken, and result was as indicated there in the case notes. Also, at our setting, we developed the management. We continued with the management, where we give aminophylline 250 milligram in 50 mils normal saline to run for 30 minutes, 8 hourly. Then we give sodium caps, then nebulization with salbutamol, IV magnesium sulfate, and then we transfuse the blood, packed red blood cell 3 units, and 3 units of FFP, and 3 units of platelets. Then investigation also was taken, which is full blood picture, creatinine, BUN, PT, PTT, ALT, AST, also HIV and serum electrolyte, that is sodium, potassium, magnesium, and calcium. Also, cardiologist was consulted for reviewing the patient, and the nephrologist also reviewed the patient. Creatinine BUN also was taken. Then the patient was continuing with the management, but later on the patient was moved from non-rebreather face mask to CPAP. Yeah. Also, management was good.
Okay, thank you, Mr. Commander. I mean, that was
other management.
Yeah, that was an extensive care for that patient. Dr. Emma, if the patient was being transported, what are the things that you prefer to see when the patient is being transferred from one hospital to the next? And from reviewing this case study, what do you think are things that were done if you, in your setting, would be doing the same thing, or do something different we can learn from your practice also? Is Dr. Emma there?
Yes, can you hear me?
Yes.
Okay, great. So I would say this patient, I think on the other page, somebody had said that she had 1,500 cc's blood loss for the postpartum hemorrhage at the first facility, at the original facility.
Yes.
Yes. So this is definitely the kind of patient that I would have called hemorrhage on. Definitely, I think she would be qualifying for this massive transfusion protocol, especially if her bleeding is not improving. And so, you know, the blood would be given, the FFP. I don't know if they did any labs on the patient at the original facility, but if any of the coagulation labs came back abnormal, even in the original facility, this is the kind of patient that would also benefit from things like cryoprecipitate or fibrinogen if those numbers were found to be low. So that's what I would add. And then also when she arrived at the new facility, I don't know if she was still actively bleeding. So maybe that can be elaborated on. But if she was still actively bleeding, I would say from her vitals and her, you know, she's still tachycardic, her pulse is high, her pulse pressure is very low. It looks like she's acidotic. I wonder if she's still having ongoing bleeding. So I would think this is the kind of patient that needs further stabilization. So continued massive transfusion protocol. I think when we talk about massive transfusion protocol, we're thinking patient is probably going to get more than 10 units of blood easily just to save her life. And so we would then be using a laid out protocol that's available in the unit and where we have all the team involved. OB anesthesia is key. But, you know, blood bank and the nurses, we would be following a protocol that we already have set. Like if she's already received 4 units of blood, then she should be getting some FFP too. What are the labs showing? Did you do a PT, PTT? Did you check a fibrinogen? And so depending on the lab numbers, then you can tailor how you're going to proceed with that massive transfusion protocol. And the labs at that point would probably be checked like every half an hour or so.
Great. Yeah, it's documented here, the clotting time is greater than 30 minutes.
Yeah, that is high.
That's very, yeah.
Dr. Mugalu, if this was your patient and you were in charge of identify this patient and then transferring to Muhimbili, what else could you have done to this patient?
To this patient, I think we would consider giving the patient magnesium here before transfer to Muhimbili. However, because they said there was no urine output, and part of the contraindications of magnesium sulfate is the patellar reflex, if they are absent, or the respiratory depression, or when they have insufficient urine output. So we would definitely discuss with the specialist on the possibility of giving magnesium sulfate, but we will still transfer this patient because we still miss some facilities. For example, this patient would need a nephrology review, a cardiologist review, would need arterial blood gases tested, and all of those things are not available at our setup. And we also don't have cryo precipitate. We don't have the platelet transfusion. We don't have partner RBCs. We only have whole blood. So we would definitely consider immediate referral to this patient.
Thank you, Dr. Mulagu. Dr. Mulungu, this patient is in your area as anesthesiologist there, receiving this patient who is a very compromised patient. What do you do different or anything that you can add to this case?
Yeah, this patient, because actually this patient was not planned for surgery or was supposed to be admitted to ICU, right? If I'm not mistaken. And my question, first of all, I didn't know what was the indication of aminophylline in this particular patient. I was thinking more of eclampsia in this particular patient, and maybe this patient, what could be done is to try to see if ABC could be done. You check the airway, the breathing, and if patient was need oxygen could be given, and if there was need for intubation, and admit to ICU, and then call the doctors like cardiologists if there was a need. But I think this patient also was having clot pause, wet chest crepitations. This was due to the problem of I'm not convinced that it was due to heart problem. What I would think is part of the problem, part of the disease of the eclampsia. Maybe the patient was overinfused and was having very poor urine output. I think, sometimes we are stuck when we have these kind of patients. They have poor urine output and they have eclampsia and they bleed. You have to give fluid. Give too much of fluid, you go to the lungs, because the patient has, there is increased capillary permeability. Sometimes they develop edema. Was edema caused by too much fluid? Nobody knows. Was edema caused by the heart? It's not bad to check the heart. You can rule out heart disease, but could be the part of the problem. And then try to in the ICU, well, these days they can do hemodialysis in ICU. If there is a need for that, that could be done as well, and call other doctors like cardiologists also to rule out heart disease. That's what could be done. There's nothing more. In here, we can't do. We will do in the now we are doing bone marrow transplant. I think we can't have a fibrinogen level. So, and we are not having the cryoprecipitate. That's the problem. So if a patient is having DIC or acute blood loss, sometimes you just give but not the cryoprecipitate. So sometimes we're stuck, we don't know what to give. Give platelets, you give fresh frozen plasma, you give or blood or pack RBC, that's all. That's more you can give. But we are, we are pressing we are trying to see if in the near future we can have the cryoprecipitate. But this cryoprecipitate has to be produced in the lab. And it will, I don't know what even they might be, how, there's there's a machine for that. And why we are not doing, I think we have to wait and see.
Thank you, Dr. Mulungu. I'm going to let
And
Dr.
we don't have a hematologist. We don't have a hematologist in this group who can tell us why are we not doing why are not having the cryoprecipitate, which is important when you are a patient who is having acute blood loss, to know where you are, to know if the problem is hypofibronemia. Okay, if that is the problem, then cryoprecipitate can be given, or could it be given blindly even? Maybe blindly could be more dangerous if the fibrinogen level is normal. So these are the things we need to improve as well. If someone is bleeding, do we know the fibrinogen load? You give fresh frozen plasma will not have enough fibrinogen in the fresh frozen plasma. So if patient needs cryoprecipitate, is it available? And if it's available, can we get it on time? That's a problem, because we are having problem platelets on time. Sometimes we get, but not all the time we get problem when we need. I mean platelets when we need, platelets concentrate when we need. We don't get on time. You can get platelets maybe in the ICU. When you are in theater, you are waiting for platelets. You get the platelets when the patient is after surgery later on. But sometimes we are lucky, we can get the platelets. And these are the problems, these are the challenges we are facing in our setting. Thank you.
Thank you very much, Dr. Mulungu. I'm going to let Dr. Gwen through this case study, and I know she was talking about the massive transfusion. How would you add to it, Dr. Gwen, if this patient is in your unit that time and they call, Dr. Gwen, come and help us? What would you do? Add to it?
Could you go to the next page?
Oh, sorry.
You know, in just reviewing from the beginning, the patient was seizing and the patient didn't receive any kind of treatment, right? From the beginning, the patient had a seizure. She had 2 seizures before she even arrived.
Yeah, they did say no magnesium was given, magnesium sulfate was given, not there. Okay. Or another medication, yeah, for the seizure. Yeah.
Okay, well, that would be one thing. You're not going to have good outcomes if the mom is seizing and there's no treatment for it. Then here, the patient is already extremely acidotic. The clotting time is greater than 30 minutes. So what actually did the patient get from that point? Did she receive anything? If you go back to the other page, the patient got all these things up front. Got the blood up front and all of that. First of all, I think she was overloaded, number one, with the 7 liters of whole blood. And I think that sort of precipitated some of the problems that the patient had when she was transferred. So go to the next page again. Yeah. So yeah, I mean, things like cryo and all those kind of things, this patient really should have benefited from, because if the bleeding time, if the clotting time is already greater than 30 minutes, then you know there's some clotting factors that need to be replaced. That's the bottom line. The fact of the matter that the patient is so acidotic right now just gives me an indication that the patient wasn't treated properly in terms of how. Let's go. Patient was conscious. Okay. Patient was on a rebreather, dipsy, no urine. She was conscious. Not pale cyanotic, life signs. Okay. Yeah, I think it's just clotting factors that she needs at this point. Yeah. Because she's weight alert. She has a Glasgow of 15-15. She's not cyanotic. But in the first opening, it says that she was on oxygen, non-rebreather, but she was dyspneic. So my concern is she's having difficulty, but she's not, hold on, go back. She's not cyanotic and not pale. Respiratory rate is 15. No, she's on 15 of a non-rebreather?
Yeah.
Okay. Yeah.
Okay, so Mr. Kamana, I think you had Dr. Gwen's questions. Like from the identification of the postpartum hemorrhage to transfer to do the ABGs, how long was that, like time was, if you can guess? I mean, 30 minutes, an hour, 2 hours, to see how the patient was, I mean, anesthetic for how long? Mr. Kamana?
Yes, you know, in our ICU, we do not have an ABG machine, but in the next floor, in the neonatal ICU, there is a machine. So when we are in need of an ABG, I think this is done very fast, very fast, less than 30 minutes. You know, as you can see here, the ABG results are out, but other investigation are not. We are not out at during the arrival of the patient. But you know, an ABG results can be done even less than 30 minutes because the ABG machine is up floor there and the next floor from up.
Okay. So I think from what the suggestions and feedback from different contributors, I mean, we know this patient was very sick and there's a lot of multi-organs improvement. And yes, so definitely we needed more than one department. So I know Dr. Mlungu said about having a cardiologist, Dr. Gwen already added that. Dr. That also added, she said, I mean, there's a lot of things that you have to worry about. You cannot just order magnesium sulfate, you have to see the kidney function. So there's a lot of stuff you can see, different discipline have to be involved in this patient. So the time is of essence. So when we are planning to transfer this patient, really we have to give them the best chance to be able to arrive where they're supposed to go to high acute level and to be taken care of or resuscitate. So in doing that, we go to the our next. Go back. Oops, sorry. Okay, so in do that, usually we have to prepare what we need to do before we transfer this patient. So even getting ready for having the to transfer the patient who is experiencing postpartum hemorrhage. Certain things that we need to have. I know Dr. Emma provided this. They usually have like a little printed out reference points for postpartum hemorrhage. If it happens, how do you classify those people? So we have to have that in place. And also, she mentioned about classifying the patient as soon as they come in, low risk, high risk, whatever, and then identify this patient stage 1 or 2. So those are things that as a resource for our colleagues in Tanzania, this is things that we can work on and try to identify those areas to have it systematically and make sure every single patient who touches it provide similar care, like, you know, things that standard things that need to be done for every single patient who is experiencing postpartum hemorrhage. We did one training in Congo last year and doing postpartum hemorrhage. And then so one of the areas that it was just the basic things, but still it was important for every healthcare workers to do is to identify how much the patient lost after the delivery. So you can have estimated blood loss, or you can have quantify blood loss. So here in the US, we quantify blood loss, meaning like we have to weigh every single thing that is going to touch that patient's blood. Like if the pad, the bed sheets, the gauze or the sponges and stuff, everything that we have to touch the blood, it have to be weighed to have an accurate blood count. So we do have, like on our documentation system, we have the weight of dry items that are used in either the delivery room or the operating room to make sure we get an accurate number. So that dry weight is already in the system. And then so as a nurse, when you get those wet wet items from when you're taking care of the patient, you weigh it on the scale and then you input that information on the computer and then it just tabulates to make sure, okay, if the dry, the wet check with blood soaked, you weigh it and it's 150. So then when you go and minus the dry weight, which is, let's say for the second, the pink pad is 24. So you minus that weight and then you get the actual estimated blood count. So we do 1 gram is equal to 1 ml. So we can transfer that data easily. So we do have, from Buguruni, they have a protocol. So it's something that if you have it, every single person needs to know where it is. So then you can come down and always systematically provide that care. So this is one of the items they share with us. And then, of course, in the US, we have identified on the postpartum hemorrhage kit, yes, which has all these things that one of them is team leader. People have to be identified who is doing what and when and how many people can come. And then, as I said, we're going to discuss it with our colleague in Tanzania to try and figure out how many people are available right now and what are the roles they should assume when they're taking care of it. And this is going to be in preparation for the training next month, in September. So on the hemorrhage cut, we have specific things that are written down, as I said, either for first-time person who is taking care of this patient or somebody who has been there in the unit for 10 years. All of us have to do exactly the same thing. As I said, we're going to share this information with our colleague in Tanzania and see what is applicable for you guys. So we have those cuts and different drawers have different things. Like so when we have a postpartum hemorrhage kit, as you guys said, you call and then we drag the whole thing to come and say, here it is. So we need an IV, we need to draw labs. Everything is in there. You don't have to keep running back and forth. Just bring the cut in the room and take care of that patient. We have everything is settled down like that. And then this needs to be checked with every shift to make sure everything is done. If somebody used the items from the previous postpartum hemorrhage event, then in between, somebody have to restock this and be able to save it for next time. We do have the back rib. I know one of the first case, they use the back rib, the balloon to stop the bleeding. So then we usually different types of balloons to be able to do that. And then of course the dry weight and stuff. And after event, every time we have an event, you have to discuss what is happening because you want to make sure we know what did we do right or what did we do wrong, what can we improve on it to make sure we prevent complication next time. And then, so we do have this video, I'm gonna play, it's like 5 minutes. And then, so we're gonna make sure everybody is aware of using this non-pneumatic Anti Shock Garment. It's something that in Tanzania, I believe they've heard about it, but they're not using it widely because either it's not there or it's not easily accessed. So we are trying to work on it and bring it with us when we come for training. And then, so this is just a little video to show what it is. It's a very simple process once you know what to do and what it is going to do. I'm just going to show the little video and then I'm going to get Dr. Randall add to it. And then that'll be our last thing for the discussion today. So let me, oops. Sorry, I just want to go to. Can you guys see my screen?
Yes.
Oh, you can?
Yes.
Okay, sorry. I think I came out too fast, but I was like, I couldn't see. There we go.
Longing for a good vacation? We have great news.
It consists of segments that close tightly with Velcro, shunting blood from the lower body to the core organs, increasing blood pressure and increasing preload and cardiac output. The main purpose is not to stop bleeding, but to reverse shock and reduces obstetric hemorrhage. It is used to transport the patient to a better healthcare facility in the case of massive obstetric hemorrhage. Placing the NASG. This involves putting the NASG under the mother, aiming for the top edge of the NASG to be at the level of her lowest rib. Close segment 1 by tightly wrapping around each ankle. Segment 2, place segment 2 tightly around her calves. Closing segment 3. Segment 3 should be placed tightly around her thigh. Segment 4 goes around the woman with its lower part at the level of her pubic bone. Segment 5 is the pressure ball. It should go directly over her umbilicus, and thereafter close segment 6 over the pressure ball. Make sure the woman can breathe normally with segment 6 in place. Also, make sure that you leave the knee free so that her legs can be bent. Removal of the NASG. This happens after 2 hours, whereby patient is stable in terms of her blood pressure and pulse rate measurement. There should be no further obstetric hemorrhage. Removing of the NASG involves firstly removing segment 1. Wait 15 minutes. Measure her pulse rate and her blood pressure. After 15 minutes, if she remains stable, then remove segment 2. And progressively, segment 3 after 15 minutes, whereby her pulse rate and blood pressure is stable. However, should she deteriorate, we should then close segment 1 again, progressively up to segment 3. This is to demonstrate a deterioration in the condition of the patient, and whereby NASG is then reapplied. Assuming that the patient is stable, we should then repeat the steps of removing 1, 2, 3, 4, 5, and 6, pausing for 15 minutes in between each segment, checking that the patient is stable.
Okay. Okay, so that is one of the items that we are thinking of bringing with us once we get all these things squared away. And I'm gonna let Dr. Gwen just add to it if she has any information about that practice.
The one thing that I have to say about this is definitely it's life-saving. It buys you some time, highly recommended. And since we go from a lower level of care to a higher level of care, it really should be part of the transport system. Since, you know, it's the facility, there's time between point A to point B, there's traffic, all these kind of things. It can be a life-saving maneuver for these patients. So I would advocate for each facility to have one. And if the facility doesn't have one, most definitely the EMS system or, you know, transporting system, whatever that they have, they should really have one of these for these patients. And so the cost really, when you think about it, the cost really not that great. And we're working on trying to find out, okay, if we have the cost of the device, then how much does it cost for shipping and handling and all those kinds of things? But if it's something that can be purchased in Africa, where we can defer some of those costs, then, you know, we can actually work on maybe even have donations to have hospitals being donated to the hospitals. And they come in two different sizes. They come in small, and then the other one is medium and large. And so that's what I have to say about it. I mean, every place that transfers patients should have one. And
Yeah.
as you can see, it's a very systematic way that you can do it. And in terms of putting it on, as well as a systematic way of taking it off. But once if the patient is still not responding, then you can go back and start to, you know, add the different, like 1, 2, and 3, as they say, up to kind of give you some time.
Yeah, no, I definitely appreciate the feedback, and I appreciate you working on it, contacting UNICEF and getting the background so we can try to secure this. We do work with Dr. Martha Mukonyi, Dr. Sunday, and Dr. Robert to try and get the logistic part behind it settled, and then so we can bring them during our training. Because as Dr. Gwen just said, it is a life-saving. So when Mr. Kamara was talking about that patient arriving at Muhimbili, and also Dr. Mulungu was adding to it, if you have that patient is already compromised and it's not stable, I mean, for even them to work on it, it doesn't matter how good Muhimbili is to take care of this patient. The patient is already way compromised past the resuscitation event. So it's going to be harder. If we can do this part just to at least maintain that patient during the transport until they get to Muhimbili, so Muhimbili can take care of it, that would be a huge support to what we can do to these moms. Because remember, having a baby, you intend to stay with that baby so you can raise that baby. We don't want that mom to lose their life because of that and because we couldn't take care of them. So it is very much needed device, especially for our hospitals that are transferring the patient to the higher level of care. So we do need to work on it and continue using our critical thinking, whether we have all those resources or not, to try and address these patients. Earlier identification is going to be the key for these patients. Prevention is better, and majority of the postpartum hemorrhage events are preventable. So if we identify early on, we should be able to prevent them. Every single mom is going to bleed, we know that. But how much is acceptable? That's part which we can affect that difference and try to improve the outcome for this mom by being more prepared. And that's why our goal for our training in September is to get all our healthcare workers prepare for every single mom who come and deliver to their hospitals, to make sure that we can address it and prevent the postpartum hemorrhage as much as we can. Dr. Gwen, Dr. Mulungu, if you guys have anything else, Dr. Mugalu?
I don't have anything else.
Okay, thank you. Dr. Mugalu?
I'd like to thank all the participants for adding so much knowledge. We knew about so many drugs. we could give to patients with PPH and about the anti-shock garment. And thank you for all the initiative that you're taking to make sure we are around the same level that you guys are practicing. Yes.
Thank you, Dr. Mgalu. You guys are doing an excellent job. I mean, we learn quite a bit from what you guys are doing. All we just need is just to try and improve and continue working together. And your feedback, your honest feedback help us to be able to say, okay, this is what is going to be applicable for you. So then we target or geared to that. They say Dr. Mkonyo is the one who mentioned about this garment, which I'm grateful because she knew that it's necessary for Tanzania to have that device. That will help. And then definitely if there's something that we can help, that's what we are here for. And what Dr. Gwen said, when we got there, we want to try to make sure everybody knows that she's going to share more of the massive transfusion protocol with everybody. So at least we can get that revised or improvised or whatever we have, as long as we address the need for that patient. So I thank again, Dr. Gwen, for that. Dr. Nestor?
Hello. Yes, I have. This is my first day here, and I'm very glad, and I've learned a lot. And I thank you guys for this. And yes, I originally know how it works in Tanzania because I have been there and I've been working there. So, and working in Sweden helped me to see this, what you are doing, like it's a very big part. It can be sometimes difficult to come to the level, like to connect, okay, we can do this. But I think this is very, very good. And I have maybe 2 points to add or to ask. One is for 1 week ago, I was in, we wanted to do this vacuum evacuation because of like missed abortion, and the woman came with bleeding, and then the pregnancy was sitting in this previous scar. And then this woman has a risk to bleed profusely if you do like vacuum, because the pregnancy was there at the previous cesarean section scar. And then I saw they were like mobilizing a device which is called Cell Saver. And then I tried to ask them about this device, how it is very cheap according to them, according to my colleagues here. It is called Cell Saver. And then because I've never heard about this device, and they told me Cell Saver is like a device which it can collect the patient blood, the same patient blood, and the blood passes through like the normal saline and pass through the heparin, and then about 80% of the blood is like given back to the patient. We normally do in Sweden. They can use this device if you expect maybe the bleeding it can be very massive bleeding. Then you have this device, and it is very useful for maybe for Jehovah's Witness patient that they don't need someone else's blood. Then the same blood, maybe about 80%. It has also like disadvantages and things like that, but it is likely to be, maybe I thought about it, like it can be very useful in our country. And then I want to ask you if you have heard about it and if you know how it is, because I thought this, I just came in to know this for 1 week ago. Then I want to know if you are aware of it and if you can, yeah.
Yes, very aware of it, very knowledgeable about it. And we use it for trauma patients, especially we use it in patients that are going to like big bloody back cases. It's used. And so, yeah, I mean, it's a device that's readily available here in the United States and not that hard to use at all. You're right. Right. But sometimes you have to be careful because some of the Jehovah's Witnesses will not accept it, Cell Saver blood. It has to be a specific way that's done. So it's not just a routine way for the Cell Saver for them. Yeah. But yeah, Cell Saver is an option. So we can like look at that too. But again, the patient has to have enough blood to run through the cell saver in order to give it back to them, because you're giving the patient back their own blood. But if they don't have any to start with, then cell saver is not really going to help you.
Excellent. Thank you, Dr. Nestor, for the suggestion, and thank you, Dr. Gwen, for offering that. But yeah, so that's the reason we have this meeting, so we can have hearing best practice wherever it is, and then try to work on it to try and introduce or bring it to Tanzania so we can work and save our patients. Sada, you have your hand raised.
Okay, thank you, doctor, for having chance in contribution. But I have one, I am reminding us one practice on abdominal water compression. As you see, with the first presentation, the second, almost a patient lose up to 2 liters of blood. But if we are clinical practice on abdominal water compression, we can minimize. So it can be PPH, but it's around 300, at around 700 mils up to 100, but up to 200, possibly there is, we forget to do abdominal water compression. So it's better to remind us to do this practice. It is very necessary, because even though you can give patient a blood product, but also there is an adverse effect when we give them a blood product. So in order to minimize mils of blood during PPH, mils of hemorrhage during PPH, it's better to practice an abdominal water compression. Thank you.
Thank you very much. Where do you work? Which hospital?
I'm working at Meatu District Hospital, but currently I'm a resident here.
Okay, thank you very much. Yes, I just wanted to know where it is. Thank you for your feedback. I agree. There's a lot of best practice that we do now. If we need to enhance them or just make sure we share that knowledge, I agree with you that that could help. Instead of waiting, we can do prophylactically to try and minimize the complications. So that would work too. So thank you very much for that feedback. Anybody else has an last minute word, and then I can let you guys go. I want to just thank you everybody for coming, and I know it took a little bit longer, but thank you for all the feedback. I know postpartum hemorrhage is the big things. According to the numbers from Tanzania, it's like 46% of the moms who are experiencing postpartum hemorrhage end up dying from it. So we need to change that number slowly but surely, but we need to change them. The one way we're changing that number by sharing best practices. There's no right and wrong things to do, but if we don't have any resources, we need to use our mind, critical thinking, and share best practice, and then try to help these moms. So QHSC is gladly and humbled and honored to have this opportunity to be able to get. We have almost 37 global volunteers who are going to Tanzania in 45 days. So one of the areas is postpartum hemorrhage, prevention of postpartum hemorrhage. So we have some training. So a lot of discussion today is going to be included in those topics. So we are excited. Thank you, Dr. Mlungu, for sharing your best people to come and help us with the postpartum hemorrhage training. Thank you, Dr. Mugalu, for the feedback and the ongoing contribution to the QHSC. We do need your feedback, everybody. Dr. Nestor from all the way from Sweden, thank you. I hope you come back. We're gonna start sending you more invitation to come back and join us. And Saada, so should I call Dr. Saada?
Yes.
Yes, okay. I didn't want to. So Dr. Sada, thank you very much for coming, and I hope you can come back. And if you can send me your text and email, so when we have all this invitation or any questions about the postpartum hemorrhage best practice, then I can reach up. And then if you have time, you can come and join us and share your expertise. Mr. Kamana, thank you very much for providing that case study for the second one. It's very well case study. So we've learned quite a bit, and we know at least the current practice of Tanzania. And so we can try and work with you guys to try and develop something that is going to help. And Dr. Mlungu, thank you for always coming back and providing a feedback. And I know you have a hand raised, so if you can finish up with us, go ahead. Dr. Mlungu.
No, I didn't know what it means. I thought it's great. So I did not. What does it really mean? That thumb up. What I meant to yeah, you know, I don't know what it means. That thumb up. Thumb up means great, right?
Yes.
So that's what I meant. So I didn't want to comment anything.
Okay. But anyway, thank you. 2 thumbs up for you.
Okay, thank you.
Very much, everybody.
Okay, bye-bye.
Yes,
Bye-bye.
we appreciate you. Come back. Don't get tired. Come back. We need to see you again. Thank you.
Thank you.
If you're actively involved, send me a message or text, then we get you to be one of the contributors next training. So thank you again, everybody. Have a great Thursday afternoon.
Okay, thank you. Thank you.
Bye, guys.
Bye.
Bye.
So much dictated.
Yeah, thank you.